Welcome, dear students. May the Almighty bless you all with peace and tranquility. So today's topic is pediatric airway. So we are going to discuss what are all the changes in the pediatric airway when compared with the adult airway, and what is the importance knowing these changes in the pediatric airway anatomy. So the changes will impact on the airway management and ventilatory management of the pediatric age group patients. So you should have a knowledge about what are all the changes and what are all the impacts and how to manage these impacts. First, regarding the head and occiput. In case of infants, these are all the very large, and any neck flexion in the supine position. So this will lead on to the airway obstruction. And also, when you are doing a laryngoscopy or endotracheal intubation process, it will compromise very badly the airway axis alignment. That is, the oral, pharyngeal, and tracheal axis should all come in one line. So this will be hampered. How to overcome this difficulty? This is very simple. So in the infants and small children, keep a rolled sheet under the shoulders. Remember, it should not be kept under the head, which will cause further flexion of the neck. So it should be kept under the shoulders. And in the older children, you have to keep the older sheets under the head and occiput. So this will give a neutral or mild extension, sniffing position, and it will avoid the hyperextension. So the laryngoscopy will be easier and successful. Next, the face and eyeballs. The structures are very soft, and the skin and mucous membrane are very thin and soft. So when you are doing a bag mask ventilation or using non-invasive ventilator with a mask, then the undue pressure over the eyes and face will cause soft tissue injuries or eye injury. Sometimes overpressure may even lead on to visual impairment. So you have to protect the eyes and you have to avoid any undue pressure over the eyeballs. So during the process of bag wall mask ventilation, in an emergency, we will forget all these things. But it is the most important thing we should never forget. And then regarding the nose, and infants and small children, they are obligatory nose breathers. When there is a nasal mucosal edema or adenoiditis, so they will produce the upper airway obstruction. So the management is clear the secretions by using suction, do airway maneuvers, and in addition, whenever necessary, don't hesitate to insert an oropharyngeal air. And then the nasal passage. Nasal passage itself is very soft and narrow. The septal cartilages, the nasal septal cartilages, are not well developed. So when you are pressing too much, when you are using a bag was mask ventilation, then it will completely occlude the nose as well as the nasal passage. So when you are doing this, you can see suddenly the drop in the SpO2. So you will be having a doubt why it is caused, but only because of the undue pressure you are giving over the nose, the airway is occluded. So avoid the pressure over the nose. Next is the tongue and the palate in the oral cavity. Tongue is very large. So there will be a difficulty in using the laryngoscopy. There will be difficulty in the endotracheal intubation. Not only that, in sedated or obtunded or paralyzed patient, the large tongue may cause upper airway obstruction. So instead of a curved blade, you can use a straight blade because the straight blade is thin. So the tongue can be pushed to one side, that is always to the left side, to get a room on the right side in the oral cavity for visualization and passing the tube. So if there is an airway obstruction before the intubation, then put the child in the lateral position, do airway maneuvers. In addition, you can use airway adjuncts appropriately. Then the palate is very soft structure. See, when we are using an oropharyngeal airway, we will be using the technique of 180-degree rotation. So this will cause injury to the palate. Not only injury, the bleeding may start. So this will obscure your view and it will hinder the process of the laryngoscopy and intubation. So directly you apply the oropharyngeal airway by depressing the tongue if necessary. Next one is tonsils. The normal tonsil size will not impair anything. When the tonsils become enlarged, so it itself may be causing a difficulty to ventilate and intubate. So here we have to resort to a nasopharyngeal airway usage. The airway should be well lubricated, as gently as possible should be passed, should not be giving any undue pressure to cause the damages to the nasal passages, which may again cause bleeding. And mandible is very small. And the most important, you have to remember about the epiglottis. The epiglottis is very long, floppy, omega shaped, and it is hanging over the glottic opening. So when you are doing the laryngoscopy, it will obscure the view. How to overcome this problem is use a straight blade, Miller's blade, and lift the epiglottis upwards so that you can have a clear visualization of the glottic opening. Another most important thing, insertion of the supraglottic airway devices like LMA or IGEL. The long foldable epiglottis, when you are inserting this supraglottic airway device, will be folded on itself like a U shape and it will be occluding the glottic opening, causing airway obstruction. So the patient will go for immediately hypoxia. SpO2 will drop suddenly. The remedy is immediate recognition, immediate removal of the supraglottic airway device, and re-oxygenate, again reposition the child, reinsert, calmly and coolly reinsert. Okay, this is the most important thing. Next comes the nerve's innervation to the glottis, larynx, and carina. These areas are richly supplied with autonomic nervous system. There are two components, parasympathetic and sympathetic. They are balancing each other. In the pediatric age group, there is a predominance of the parasympathetic nervous system because the sympathetic nervous system not yet fully developed. So any stimulation of the said areas by the process of suctioning or intubation or laryngoscopy may suddenly cause bradycardia or laryngeal spasm or bronchospasm. So always avoid stimulation. And already if you're constantly stimulating, immediately remove the stimulation. And the procedure should be done under adequate analgesia, sedation, and paralysis. So, if necessary, you can resort for the other medical management. And regarding the larynx, it is more cephaloid or superiorly positioned, and the shape is funnel shape. The vocal cords in infants are more anteriorly placed. Both these things will cause visualization of the cord difficulty. So the management strategy is again keeping a folded sheet under the shoulder and using the laryngoscopy. When necessary, you can apply a external laryngeal manipulation. Or even if it is found to be difficult, even from the beginning, we can go for video laryngoscopy. And regarding the tracheal diameter, the length as well as the diameter of the trachea are small. Diameter is very narrow. Any mucosal edema, for example, croup, pertussis, or any secretions. They will easily cause airway obstruction, maybe partial or. So this will lead on to the increased airway resistance. The diameter is narrow, further increase in the airway resistance, which will cause the increased work of breathing and increase the oxygen demand. The management of this problem is only clear the airway, again using a suction in the breathing, and bag mask ventilation and appropriate medical management. Regarding the tracheal cartilages, the trachea itself is a soft and pliable. The cartilages are not fully developed. So the trachea is not as rigid as it is in the adult patients. It's usually collapsible. If you stretch it, it will collapse. Okay, you fluctuate, it will collapse. Okay, so this is the most thing. So when the neck is hyperextended or stretching of the trachea during bag wall mask ventilation, so the tracheal diameter will be further decreased. This will lead on to the airway compromise. As also neck flexion may cause kinking of the trachea. Again, it will cause airway compromise. So always avoid hyperextension or flexion of the neck during oxygenation, during bag mask ventilation, during laryngoscopy and endotracheal intubation. And the length of the trachea, unlike in adults, it is very short. How does it have its impact? When you are passing the endotracheal tube, the tube should be at least 1 centimeter above the carina. The endotracheal tube should not touch the carina or should not be very close, at least pediatric age group 1 to 1.5 centimeters above the carina. You should not go very deep inside or you should not be outside also. So any neck extension may cause the endotracheal tube displacement outwards. The tube tip may dislodge into the larynx or hypopharynx sometimes, or it may be getting extubated. The opposite, that is the neck flexion, may push the endotracheal tube inwards. Commonly, it will be go into the right main bronchus, causing one lung ventilation. So how to overcome this? So adequate depth of the tube should be inserted inside, and it should be anchored very well. And regarding the cricoid cartilage, cricoid cartilage is the named cartilage of the trachea. It is the first tracheal cartilage. It is the narrowest portion in small children. So we have discussed that larynx is a cone-shaped structure. The first tracheal cartilage is the narrowest portion. So when you are calculating an endotracheal tube, so you always keep one size smaller. Visualize the glottic opening. See, sometimes if you want to pass a 4 size tube, it may not be negotiated. It may be going with resistance. In that case, don't press it too much. And you can go immediately to a smaller size, that is 3.5 size tube. Optimum appropriate size is most important. Larger tube, or when you are using a cuffed tube, high pressure of the cuff, both will cause ischemic necrosis. So always use a correct size tube. Don't force bigger size tube. Optimum cuff pressure should be maintained and periodically cuff pressure should be monitored. Again, being the narrowest portion in croup, leading to edema formation, leading to airway obstruction, is managed by medical management, by bag wall mask ventilation. Rarely it may necessitate the need for an intubation. And cricoid pressure. So there is the biggest controversy whether to apply the cricoid pressure or not. Why the cricoid pressure is applied? In order to prevent the regurgitation of the materials from the stomach to come into the throat and getting aspirated. This is the purpose of the cricoid pressure when you are doing the process of laryngoscopy and intubation. So there is a controversy. The cricoid cartilage in infants and smaller children is very small. It is difficult to identify and it needs an expertise to give the pressure. And furthermore, the respiratory passage, larynx and trachea, poor developed cartilage, soft, pliable structures, the pressure may cause airway obstruction. When you are doing a bag wall mask ventilation, it will be difficult or ineffective ventilation. And doing a laryngoscopy, it itself may cause visualization difficulty of the glottic opening. And furthermore, there may be difficulty in intubation. So better avoid cricoid pressure, or if already using the cricoid pressure, at least release the cricoid pressure. Okay. Then coming to the cricothyroid membrane. The membrane size is very small. And in infants, very small children, it is difficult to identify. When you have to resort for a rescue airway, that is cricothyroidotomy, so less than 10 years of age, only needle cricothyroidotomy is indicated. Surgical cricothyroidotomy is contraindicated in age less than 10 years. But more than 10 years of age, you can resort to either surgical or needle cricothyroidotomy. But remember, the surgical cricothyroidotomy or tracheostomy in this age group patients should be done only by experts. And epiglottis, larynx, and redundant soft tissues around the airway and neck. They are all very soft, they are prominent, they are mobile. So when you are lifting the laryngoscope blade, so it will lift the esophageal also, inlet also up. So when you are visualizing, you may mistakenly think the glottic opening as laryngeal inlet, and you may pass the tube into the esophagus. So whenever you are doing a laryngoscopy, should do it slowly and gradually, step by step, advance the blade. 1 centimeter by centimeter, you advance the blade. And then gently lift the blade with minimal force, always keeping a constant look at the oral cavity and glottic area. And already you have passed too much inside the blade. You slowly withdraw the blade, and now the glottic opening and epiglottis will be visible. Then you can pass the endotracheal tube. One word about the chest wall, soft and compliant. Even you keep some minimal weight over the chest, that will cause respiratory impedance. For example, keeping a folded towel just over the head. In tiny babies, that will embarrass the breathing. And regarding the lower esophageal sphincter tone, that is a cardiac sphincter. The tone is very low, the sphincter is incompetent, the impacts or risk of reflux and aspiration of the stomach contents, and furthermore risk of gastric distension. This may happen in either during spontaneous ventilation itself or bag walls, mask ventilation, esophageal airway device were applied and then ventilated. So this, what is the impact of the gastric distension? In the tiny child, the gastric distension may cause reduction in the functional residual capacity. It will also reduce the tidal volume. And totally, the ventilation will be impaired. Final result is hypoxia. Not only that, gastric distension may lead on to the vomiting and aspiration. So two things you have to keep in mind whenever you are doing a bag wall mask ventilation. or non-invasive ventilation, do it in a proper way. Learn the art. And don't hesitate to insert either a oral or nasogastric tube at the earliest. So to deflate the stomach. Okay, this is more important thing, and leave it open in its place. Just put it and don't close it, because again the pressure will not be released. So deflating the stomach at the earliest. And most important thing, agitated and crying child. So we have to give more weightage on this aspect. Children, they are normally having an increased basal metabolic rate, for which there is an increased oxygen demand. This is on the demand. But on the supply side, the lungs and lung volumes and capacities are very small. And the tachypnea is the first response to the hypoxia. All these put together, it will jeopardize the oxygenation. Not only that, the crying child, the airflow will become turbulent. The laminar airflow now is changed into a turbulent airflow. So this will increase the airway resistance multifold. Once the resistance is increased, the work of breathing will also be increased, and the oxygen demand also will be increased. Finally, the child will get exhausted and go for respiratory failure. See, when the child is already having a partial airway obstruction, for example, croup or mucosal edema, there is already increased airway resistance. In addition, crying, agitation leading on to the turbulent airflow, further increase in the airway resistance. So the partial airway obstruction may lead on to the dynamic airway obstruction. So always keep the child calm, quiet and undisturbed. See, always the mothers are very comfortable and quieted by the children being on the mother's lap. Don't deprive the children from their mother. So till the induction, everything is over, the child becomes unconscious or sedated. You keep the mother also by the side, or let the child be on the mother's lap. And again, we have to emphasize regarding the bag wall mask. The proper technique is most important. Otherwise, this technique itself will be overinflating the stomach. So inflation of the stomach will also hamper the diaphragmatic excursions, and itself will cause impairment of the ventilation. So whenever necessary, we can opt for the delayed sequence intubation. So these are all the most important changes I wanted to enlighten to you all. See, we are wishing you the very best for a grand success in your examination. Face the examination very cool and calm and with 200% confidence. The positive thoughts always win. Best wishes for everybody. Thank you.